So good morning everyone, and welcome to this HCV Action webinar looking at hepatitis C outreach. So my name is Aidan Rylett and I help to coordinate HCV Action along with my colleagues Noah and Diana. So thanks very much to everyone for attending today. We've got 4 excellent speakers for you to talk about various aspects of outreach. So first up we will have Louise Hansford from Hep CU later, who will provide us with an overview of what outreach is and why it's so important in relation to hepatitis C. We will then hear from Rob Allen from the Hep C Trust on his work running a hepatitis C outreach van. After Rob, we'll have a presentation from Helen Caldwell from Liverpool University Hospitals Trust on the outreach work that took place in Cheshire and Merseyside during COVID-19 around Hep C. And finally, we'll hear from the Hepatitis C Trust's Philippe Bonnet on his test and treat outreach work in Birmingham and the West Midlands. So we have time for a few questions after all of the presentations. So please do feel free to type in any questions that you have in the chat box at any time during the presentations, and I'll then put them to our speakers once we've heard from all of them. Following the Q&A, we'll split off into 4 breakout groups where there'll be a chance to discuss the issues that were raised in the presentations, ask questions, share perspectives on outreach work, share experience that you've had. We'd be really grateful if everyone other than the presenters could remain muted during the first part of the webinar, and then when we get to the breakout groups, that's when you can unmute and speak with colleagues. We will be tweeting during the webinar. We're at HCV Action, so please do look us up and engage if you are on Twitter yourself. And just finally, in terms of the introduction, just want to note that the webinar is being recorded and it will be uploaded to the HCV Action website and YouTube channel afterwards. Okay, so I will now hand over to our first speaker, Louise Hansford from Hep CU later. Louise.
Hi everyone, I'm Louise and I work for the NHS Addictions Provider Alliance on our Hep CU Later programme. So I've been asked to speak today on just our experiences on the importance of outreach and setting the scene. So I thought we'd start today, next slide please, with just a bit of a definition around outreach. So the Cambridge English Dictionary says that it's an effort to bring services or information to people where they live or spend time. And our experience shows us that it can be done within drug and alcohol services, within homeless services, anywhere really, via our clinical vans, in set locations, church halls, food banks, and it even now includes people's houses. And I think COVID has given us a real opportunity to adapt and enhance the way that we do outreach. So next slide, please, Aidan. So these are just some photos from last year's pop-up clinics. Avon and Wiltshire Partnership, one of our APA members, secured some money from Hep CU Later to run some pop-up clinics, and they were adjusted due to COVID, but they actually won the Hepatology Team of the Year at the British Journal of Nursing Awards earlier this year in March. And over the time, we did 19 different outreach clinics in the community, in church halls, in car parks, using the van. And they managed to test, I think we had 225 separate interventions, and we engaged 78 people onto treatment. And it's worth saying that many of those were already known to the system, but have been lost along the way. So outreach gives us a really good opportunity to re-engage people and come alongside them and meet them where they're at. So next slide, please. So what we know, there's a whole wealth of evidence that traditionally service users do not attend hospital-based appointments, and that can be because of medicalised jargon, it can be because it's just simply not a priority, lack of finances. I mean, one of our outreach clinics in Andover was actually a 78-mile round trip to the local hospital. And in a car, you could do that within, like you could do the round trip within 3 hours. But for those people that had children and were trying to do it on public transport, it was absolutely impossible to do it. to drop their kids off at school, go to an appointment and get back. So as I said, it really meets people where they're at. We've got experience now where we can reach populations not engaged with service users, and some of the reports suggest that there's up to 50% of injecting drug users that are not currently engaged with prescribing services. So it is really important to be able to get out into the community. Service users do feel valued and empowered that we're taking the time and the effort to go out and actually go to them, and there's less opportunity to drop out, because we can literally, one of the things that we do in our van is we literally ring people and say, right, we're 10 minutes away, where should we meet you? And literally you can just, in a mobile clinic, you can just pull up and see people. And if you've got a regular kind of timetable of where you're going to be, obviously people know that, so they can come. And it's a real opportunity for a multi-agency approach. So you can have one of the outreach clinics we did recently, we piggybacked on a COVID vaccination clinic. So we were able to catch 7 people that needed SVRs done. So it's a real opportunity to link in with other services. So next slide, please. So what's required? We're really fortunate now with the Hep C elimination agenda that we've really got some excellent kind of human resources. So our project is a partnership with Gilead Pharmaceuticals, so they support us with human resources. As some of you might know, we've got a Gilead family growing by the day, and that's been supported by MSD, and AbbVie have supported with peers across the country. So collectively, we've really got everything that we need. But I guess the biggest thing is that willingness, to expect the unexpected, the ability to adapt and change plans sometimes at short notice. So for instance, if you're planning a outreach clinic using a van and it's hammering down with rain, you know, sometimes you have to divert or change plans. And I think we've gone from, again, COVID's given us a real opportunity where we can show that we can take positive risks, and it really benefits our service users. So yeah, I think we are at our disposal now. We have absolutely everything we need. We've got multi-agency involvement. We're playing to everybody's strengths. So it's just, now's the time really to be getting out there if you're not already. And I appreciate most areas have got outreach in some form or another. Next slide, please. So the important considerations with the multi-agency working, it's really important to consider the data and who's going to manage that process. And unfortunately, as I'm sure we're all aware, our data systems don't talk to each other. So the Hep C Trust may see some of their peers and they update that on their system. You know, NHS treatment updates it on the NHS England database, drug services map it to NTDMS on the PHE database. So really for ongoing surveillance and prevalence data, it's really important that when you're considering outreach, that you look at who's going to man the data and how it's going to end up on all the different systems that it needs to end up. So within that, it's really good at the earliest stage to look at roles and responsibilities and using each organisation, each person and each bit of equipment the most effectively. So for instance, we won't necessarily take a clinical nurse, specialist hepatology nurse out on our van every time we're out. If we're doing testing events, that's not using their time most effectively. So one of the ways that we will do it is we will do mass testing and then group a cohort of people that need liver assessments, that need treatment together, and then invite the nurses out. It's really important to have somebody that's coordinating it, and risk assessment and safety, is especially important. Where last year when we were going into hostels and homeless and hotels with the Everybody In initiative, sometimes, knocking on people's doors, asking them if they wanted a Hep C test, it might be important for us at that moment, and we might have a small window of opportunity. but waking people up first thing in the morning, sometimes, you know, I know what I'm like if I get woken up early. So it's just being considerate and thinking about the people that we're trying to engage with. It's really important that if you're going to do an outreach clinic, so some of ours that are done in the drug service are always the first Friday of the month, or the third Thursday of the month, or the, you know, every other week. But our service users will grasp onto that, and they will remember that. So it is really important that we try and remain consistent. And the other big thing at the moment is confidentiality. So we're very aware that on our van, that if we've got people on our van and we've got people outside, sometimes you can hear. When we were doing the outreach clinics in some of the photos that I showed earlier, you know, there's not a lot of space, and with social distancing, your people are further away, so people are by the very nature talking more loudly. And I know for us, like everybody that works in this field, Hep C isn't a big deal anymore, you know, and so we can become a little bit complacent and forget that for other people it's quite shameful, and people can get embarrassed. So confidentiality is a big one. Next slide, please. This week, PHE produced some evaluation slides, and the link's there, and I believe Aidan's going to send these slides out. So this gives you a really solid framework. So the problem that you're trying to address, describe the intervention, the reasons, what were the outcomes, what lessons have been learned. And the more our networks can share what we've learned and why we've done things the way we've done, then the more people can learn from it, and we can share the best practice. You know, and for me, I feel really privileged to be working in Hep C at the moment, because whereas a few years ago, what I was doing in Hampshire was commercially sensitive, now everybody gets together and we talk about it. So it's pretty phenomenal, actually, what we're achieving collectively. And my last slide, I just wanted to end my presentation. So Andover was a really rural location. They weren't served well by the hospital, and we secured some money from UK fellowship money from Gilead to bring the nurses out for outreach in 2017. And I just wanted to just illustrate that you can get everybody involved. And this one guy, I'll call him Fred, we were trying to engage Fred for many years into Hep C treatment. And he said when his girlfriend had done it, he would do it. And then he had headaches, and it got to the point where our prescriber told me that Fred didn't want me to contact him, and I was to leave him alone. And we presented our work at INSHU in Canada a couple of years ago now. And you possibly can't see it, but on the poster, he was the last one to be left to treat. And so on the poster, it had one left to engage. And on my way home, I was at the airport, and they wanted me to pay excess luggage for the poster, and I was just going to leave it. And luckily, somebody else waved me on. But I took the poster back and put it in the Andover service. And one day Fred came in, and he saw the one left to engage, and he spoke to our receptionist Amy and said, "Oh, is that me?" And she was like, "Yeah, Fred, that's me. That's you." And once he got over his little huff that he thought that we'd broken his confidentiality, you know, 3 years of trying to get this guy to do treatment, 3 years of turning up consistently, all the stuff I've spoken about, and he just wasn't having any of it. And it was this poster and that conversation with our receptionist that turned it. He asked to see us. He said to book him in with a nurse. And on the day he met with the nurse, I went in and said, "Oh, Fred, do we need to talk about some graffiti?" Because as you can see from the poster, he'd scribbled out the one left to engage. And, you know, I was delighted as soon as some of the COVID restrictions lifted to be able to take our Cepheid machine, Cindy, and do his SVR. And yeah, it just shows that you don't know when the impact, you know, it might be 2 or 3 years later, but everybody can get involved with this, and it's phenomenal. And I'll leave it there. Thanks, Aidan.
Thanks very much, Louise. That's a really useful introduction and overview, and also a lovely story to finish on there. Also very nice to have Paddington waving at us over your shoulder. I enjoyed that. Okay, next up, we're going to hear from Rob Allen from the Hepatitis C Trust, who's going to talk to us about his van-based outreach work in South London. Rob.
Thank you, Aidan, and thank you, Louise, for that. It was really great to hear you and see that presentation. It was great. So I'm just going to talk a little bit this morning and give you a little overview on the health bus and the service that we provide across South East London, and sometimes we go into Kent as well, and some of the difficulties and some of the challenges that we've faced over the last 2.5 years, you know, trying to find, test and treat some of the most hardest to reach or to engage people with the most complex needs, you know, that just don't engage in services, or they're caught up in that, you know, revolving door of in and out of hospital, in and out of, you know, opiate substitute treatment. And, you know, some of them have known that they've had hepatitis C for years. And, you know, so I thought I would just give you a little case study to start with and tell you how we sort of dealt with that, you know. So I'm going to call this guy James. You know, he's a 47-year-old male living in a hostel in South East London. You know, and it was one of the hostels that I'd been getting into regularly to engage people, and I got a few people on treatment. But every time I knocked for this guy, he was just like, no, not today. I'm really busy, you know, and all that stuff. You know, I'm clucking, I've got to go and use, you know, really difficult. And this was going on for about probably 9 months. And in my own experience, I'd never, you know, I'd experienced people not engaging, but this guy was just not talking. You know, you couldn't even get him face to face. He wouldn't even come to his door a lot of the time. You know, and I'd had a couple of conversations with the nurse from the health inclusion team about him and stuff. And she was saying he's exactly the same way as, you know, he's got venous ulcers. You know, he was in a bad way. And we just couldn't get him. And, you know, and I was in the hostel one day, you know, and I never gave up. You know, I gave him a little knock every time I was in there, you know, just to let him know that we were still about. And I was in the hostel one day and I was talking to the nurse about another patient, and she informed me that James had been working with another worker, an outreach worker, years ago, and the guy used to take him for breakfast. And that was, you know, and he would talk to this guy because he bought him breakfast. So I thought, there's the in. So I went to his door straight away and I knocked on the door, and it was the same response, you know, oh, not just now, I've got to go out, you know, the same stuff. And I said to him, okay, I'm coming back next week. I'd like to make an appointment with you, and I'm going to take you for a breakfast, and we'll have a chat about your hepatitis C. And he went, yeah, okay then. So I sort of came back the next week, you know, sort of half expecting just to get the same response. And he was ready to go out and go for a breakfast. And it was just that opportunity of having the conversation with him. You know, and some of his concerns was, you know, venous access, you know, about getting bloods, or you're going to want to get bloods off me, all that stuff. So, you know, I had the conversation with him about, you know, we don't need to do that these days. We've got a Cepheid machine. You know, we can take a finger prick of blood and we can get results in an hour. So we've done that, and we got him on the van, and we got him fibre scanned, and we got his Cepheid done, and we, you know, we found out he still had an RNA, and his fibre scan was quite low. He was only 6.5. So we put him forward for treatment and got him approved for treatment, and we brought his meds to him the week after. So we got him into treatment quite quick. You know, it was within about 12 days, we got him, you know, his tablets, and we took him his tablets, and we gave him his first month's tablets. And I kept, you know, phoning him every week after that, because that's what I do. You know, when we get people in treatment, I phone them every week just to give them that little bit of extra support. You know, and through that process, you know, he started to engage with the nurse, and he started feeling a little bit better. And he started having conversations with the health inclusion nurse and started getting his venous ulcers dressed. You know, and he was injecting into one of his venous ulcers at that point. You know, he couldn't get a vein anywhere else, and he could get, you know, he could get a hit in there. So he was quite, you know, he was in a bad way. And he started engaging with her and getting his legs dressed. Then when I went back on the third week, when I phoned him in the third week, he went, oh yeah, I've started on the script. So he started engaging with other services as well. Now, I don't know if that was through the fact that he started feeling better because he was on the medication or what, but just that change and that engagement, I believe, helped him to maybe, you know, engage in other services. And so we got him through treatment, you know, and he adhered quite well to treatment. He missed a few days here and there, but not many. You know, and we went back on Monday this week and we done a cepheid on him. Do you know what I mean? And he was non-detectable at end of treatment. Do you know what I mean? So, you know, all that time and all that effort, you know, putting into him paid dividends in the end, you know, and it wasn't a big effort really, because I was there treating other people as well and seeing other people. But it's just that thing of the added value that having that van and having the mobile clinic, of being able to get somebody on, get them fibre scanned, get them blood tests, get them cephied, whatever we do, you know, an ongoing needle exchange, giving them harm reduction advice and information. You know, it just brings that whole, it's such a wonderful intervention, you know, that, you know, and it really benefits the patients that we're working with. You know, so that's just one little snapshot of the sort of client group that I work with, you know, and he's just one in many, you know, and we've treated people in car parks, on the streets, you know, and that's part of the joy, I suppose, that we can actually take everything to clients where they're at on the streets, you know, and we have lots of people who are quite, you know, they move about a lot. So they'll go from one borough to another, begging here, begging there. And we just go about and we find them where they're at, you know, and through COVID, a lot of people were picked up, put into hotels and that, and we lost a few people we had on treatment. We didn't know where they were, and we had to go about finding them again. And we managed to track them all down and have continuity of care for them and get them through the treatment, you know, and have that flexibility, you know. And I think one of the great things about having the van is that we can go places and pick people up and have that flexibility to follow them up, you know. So I see the van as a through care and aftercare program, really, you know, because we engage people through outreach and get them through treatment. Then we have the aftercare of needle exchange and testing further down the line, just to make sure they're sustaining the treatment's still working. And then, you know, and that's what we're doing. You know, we've picked up a few lately that's been reinfected, and we're starting to get them through treatment again as well. So yeah, it's a great intervention, and I'll leave it there. Thank you.
Thanks very much, Rob. That's a really great case study and a real testament to your persistence. So thanks very much for sharing that. Just a reminder to everyone that if you do have any questions for our speakers as they go in, please do type them into the chat box and we'll come back to them once we've had the final talk. So next up, I am delighted to introduce Helen Caldwell from Liverpool University Hospitals Trust, who's going to talk to us about outreach work in Cheshire and Merseyside during COVID-19. Helen.
Hello, my name's Helen Caldwell. I'm the nurse consultant in liver disease at the Royal Liverpool Hospital, and I'm the lead nurse for Cheshire and Merseyside. So I'm just going to give you a brief overview of what we did in the summer. So next slide, please. So we're quite a big team, and soon as COVID hit, we were sort of redeployed to the wards, which was slightly scary because I hadn't been on the wards for about 25 years, but actually it worked out okay. And then once mid-June came and everything started to settle, we decided that we needed to get our hepatitis C clinics up and running. But it was, COVID had changed everything, so we had to think of new ways of working. Most of the drug agencies were closed. We'd done a few hits. Well, we'd just a week before lockdown, we'd done a hit on the prison, but that was suspended. We were having no face-to-face appointments in the hospital. We had very limited services in the hospital. People weren't coming in for bloods, and people, quite frankly, didn't really want to come to the hospital for fear. They had a bit of a fear of the hospital. But also for us to get bloods and everything from them, they had to make appointments with their local GPs and places like that, and that wasn't ever going to happen. So next slide, please. So, and next slide, sorry. So the next step. So we sat down as a group and decided what we should do. We were aware that there were a list of all the hotels and hostels that were housing the homeless across Cheshire and Merseyside. So with the help of our project manager at the time, Jenny, we decided to go through all those lists and ring them all up and ask them whether we could just come along. We decided that we needed some incentives because, as someone said on a previous talk, what's important to us, and that was to get people treated, isn't always important to them. So we decided we'd get incentives, and we got food. At the time, we just got food, and the Trust were very good at giving us food, and the Hepatitis C Trust were also excellent. We contacted the Hepatitis C Trust, and we had excellent peer support. Our regular support worker, Kieran, unfortunately was isolating and couldn't join us, and we were given Liz and Lee to work with us, who had previously worked in the prisons, and we couldn't have done it without their support. We decided that we would offer every single person an antibody test. And then we had the Kefid machine from MSD. So prior to lockdown, we had this for a hit in the prison. And then literally we came out of the prison on the Friday, and the Monday we went into lockdown. So we had this spare machine sitting in our office, which we thought, actually, I think we can use that. And MSD were massively supportive in encouraging us to do so. We then decided that we would use pangenotypic drugs because even though we were only allowed to use 20% of our patients were only allowed to be pangenotypic, that was waylaid. So they said you can just treat anyone effectively. So we decided that we would take the drugs with us. So the plan was that we would do testing to treatment in 90 minutes, which we did. Now, it all sounds very simple there, but the Trust obviously were a little bit concerned about us going out into the community with COVID. So we had to go through risk assessments. And then we had to go to another board, which my colleague Jenny was very good at sorting. They had to go to a board to say that we were safe to do so and put SLAs in place and everything. So we did this sort of quite quickly. And then our pharmacy department were excellent in allowing us to give us unnamed medication so we could take out with us and give it to the patients rather than trying to go back on a later date. So next slide, please. So this slide just gives us an overview of what we did. So during it actually says on the data that we started in the March, but actually we started in the June. We did 447 antibody tests, of which 105 were positive, which was about 23.5%. And of those 105, 65 were RNA positive, which was 14.5%. And of those 65, 64 of them were started on treatment. For the life of me, I can't remember why one didn't. And it's really bugging me, but it was a year ago and a lot's happened since then. But basically, all the patients that came back as RNA positive, we offered treatment, and just one declined. And as I say, I'm not quite sure, I can't quite remember. But it was very, very successful. We didn't really have any issues. The hostel staff were very supportive. We could go up to the clients' rooms if need be. Not everybody thought that was agreeable, but we did tend to go up to people's rooms and to knock on the doors and gave them a sandwich. And we figured out that a fizzy drink and chocolate were the two things that they liked the most. Next slide, please. So basically, compared to other people in the country, Cheshire and Merseyside, we did really, really well. And all the other people on the slide did as well. But from Cheshire and Merseyside, we did very well. Next slide. And this slide is just basically what I'm saying is that 98.5% of those patients that were tested were offered treatment, which was excellent. Next slide. So there was I've just done a little bit on a key to the success, really. As I said previously, it all sounds very simple, and it was, We, you know, we basically took medication out with us. We tested people, they tested positive. We gave them, and controversially, we gave them their full supply of medication. We did bloods on them. So when they tested positive on the Kefid machine, we would then do a full set of bloods on them. And if any of the clients, keep calling them patients, but if any of the clients didn't want to keep the full supply of medication with them, the hostel staff or the hotel staff would take them from them. And because a lot of them have lockers and where their methadone gets delivered on a daily basis and is supervised consumption from the staff, we put their Hep C medication along there, so we knew that they were taking it. Now, don't get me wrong, there were quite a few patients that we lost to follow-up, that they took the medication and we didn't see them again. Now we're a year down the line, we're visiting all these places again, and we are picking up the same people, all in different hostels, but we're picking them up, and now we're doing a lot of SVRs, even though they're 12, you know, it's 12 months down the line. So we had excellent teamwork. And as I said, the Hep C Trust were unbelievable. They were very, very, very supportive of us because, you know, I'm a nurse and I know enough about hepatitis C. However, getting them in the door is the hardest thing, even when you're standing in a hotel when their room is above you. But the Hepatitis C Trust, Liz and Lee and Kieran would stand outside and they would talk to them, and then they would bring them in. And we had, you know, without them, this wouldn't have been a success. Food incentives was also a huge hit, a really, really big hit. It was, and at one stage, in the YMCA, when we went there, we got people who weren't from the YMCA just because they heard that we had food, which is great. So it was fine. And most importantly, it was sense of humour. It was, we'd been, COVID, you know, hit us hard in Liverpool. It hit everywhere hard. And I felt, you know, for the likes of us that had never been on the wards for a while, and going back into the community, it made me realise how much I did enjoy my job. Next slide. So this was just something that the ITV News sort of just wrote a little bit about us, and Jenny Dowd, as Senior Project Manager for this initiative, just said that, you know, temporary accommodation and hostel management was very supportive, ensuring that the space is available. So they made sure that there was space available for us, and we couldn't have done it without their support, their hard work and the dedication from the Hep C Trust, Pier and the hotel and hostel staff. Next slide. So this was just a couple of pictures. The bottom picture, you'll see that I've rolled my trousers up because we were in Southport that day and it was about 105 degrees. So it'd been a long day. And the top picture is, I've done this in memory of Jenny Dowd. So I've talked about Jenny, and Jenny was our Senior Project Manager, and she's the lady in the white, the back with the glasses. Jenny, unfortunately, after she did this project, was knocked off her bike and killed in October. So this is in memory of Jenny. She was a great person, and without her support during this, we would never have worked as hard. We would never have got it done, because she did all the running around behind the scenes. So this work was really a memory of what Jenny did and how much we miss her. Thank you.
Thanks very much, Helen. That's a really useful overview of the work that you did in the last year, and a lovely tribute there to Jenny as well. I think we were all very shocked and moved when we heard the news about that. So moving on, our final speaker is Philippe Bonnet from the Hepatitis C Trust, who will be talking about his test and treat outreach work in Birmingham and the West Midlands. Philippe.
Thanks, Aidan. Helen, condolences. It's so sad, and what a fitting tribute to your colleague. It's made me all emotional I've ever met her. Wow. Thanks, Aidan. You got my presentation up? Am I doing it, or?
Just 1 second. Noah's getting it up, I think.
Brilliant. Thank you. So thanks. First slide. See, Helen, you really moved me now. Sorry about this, guys. Okay. The first slide, I wanted to start with the thank you and the acknowledgement of what I'm about to talk to you about. I definitely could not have done this work without the fantastic support of the CNSs, the key workers, support workers, you know, managers and service users. That would have been pointless task, you know. Thanks, Aidan. So thank you. Next one. I'm rubbish with slides. Thank you. Next one. Thank you. So who did I target with this test and treat project? Well, obviously people hopefully injecting drug users, and most, if not all, were active injecting drug users. Some were not accessing substance misuse services. Majority were homeless, and I also had a really high number of people with really high DNA rate, you know, for the Hep C care over the years. You know, they just wouldn't turn up to appointments and stuff like that, you know. So this was my my target audience, actually. Thanks, Aidan. Thank you. So how did I go about it? Actually, a couple of phone calls, you know, to old colleagues at MSD, who then put me in touch with Debbie at Cepheid. And between MSD and Cepheid, they agreed to give me a Cepheid machine, which I thought, okay, that's great. So initially it was for 1 week, for European Testing Week. That was in November 2019. And then Debbie and from Cepheid and MSD were very good to let me have it for 2 weeks, which came to 3 weeks, which came 4 weeks. Thank you, Adam. So with this news, I then approached Sally, our ODN lead, to tell her that we're going to offer the machine with 100 tests also. AbbVie also gave me 100 antibody swabs. Sally spoke to Prof, I would have thought, and they've agreed to issue or to free up 100 lots of Epclusa, which I was over the moon with. Thank you, Aidan. Really over the moon with this, you know. So for, okay, let's do a little roadshow. Thanks, Aidan. So where did I go? Again, to go back to what Louise was saying earlier on, you know, it's the importance, you know, the importance of building relationships, you know, and foundation. We'll talk to you in a bit. But so to date, I went to Warsaw. There's a couple of rehabs there, and a couple of soup kitchens. Coventry, same again, a soup kitchen, a couple of hostels there. And then Stoke-on-Trent, Newcastle, Stafford, Cannock, Cheadle. So if you see all these areas, you know, there's a reason for that. It's a particular person that's all on this webinar today, you know, that made me feel so welcome, that opened doors for me, and that was so proactive. So thank you, Debbie, from Humankind. You know, absolutely superb, superb relationship with these wonderful people that really made this work. You know, thanks, Aidan. So for me, the biggest selling point, you know, for service users is I'm not going to ask you to go anywhere, you know, or travel anywhere. You know, I think I've been quite vocal over the years when it comes to Hep C, and I really strongly believe we need to take treatment to people and to make it as easily and seamlessly and as painfully as possible. You know, so I was very lucky to be able to offer people to test and treat them in only 2 visits. You know, they will not need to go to any hospital, pharmacy, drug service, GP surgery. No, I will come to you. You know, I will give you a result within an hour. You know, and if it's positive, you know, the full course of medication will be given at the 2nd visit, which some places took 1 week to 10 days to a couple of weeks maximum. You know, so it's quite a high, very quick turnaround. Thank you, Aidan. So I thought that was a massive, massive selling point. You know, thank you. So how did I go about it? Well, I thought some places I need to build some foundations because I've never been there before, you know. So what did I do? I contacted those hostels managers. I've offered to do some hepatitis awareness training for them. 2-hour session for the staff and their residents. And then you see when you do these training sessions, you quickly identify what I'm calling my Hep C champions, you know, staff that keep asking questions. They say, I've got a patient, when can I bring him? So you can identify those people, you know, they're keen to help, you know, and this is the one that you want to nurture, you know, and work with very closely, you know. And obviously, I've already had existing relationships from my previous roles, you know, as in services. So obviously made use of them, contacted my old colleagues who said, listen, I've got this piece of equipment where I can tell somebody within 1 hour if they have Hep C. And they were like, wow, when can you come and, you know, and bring this service to us? Because we'll put people in front of you, you know, and that's what's been happening, you know. Thank you, Aidan. So, I mean, thank you. So the path was pretty simple, you know. I mean, one thing I forgot to say is I devised a poster to send to those hospitals and, you know, providers, you know, highlighting the test and treat in 2 visits. And the beautiful things is all them hospitals, they would literally print the posters, put them up. But the day before, they would put them under the resident's door. You know, I said, don't give them the week before, the month before, this pointless, the day before, just to remind them, you know. I also add that the wonderful faith at AbbVie offered to bring donuts, you know. So hospitals provided tea and coffee, AbbVie provided the donuts, winning combination, right? Show us for me. And so I would turn up there. The wonderful staff put people in front of me. So quickly by doing the consent form and the assessment, you know, I would do a quick antibody test, all right, within a couple of minutes. Any positive, I would then do a Cepheid test. I quickly learned that, and I'm sure some of my colleagues will echo this, you can test somebody and tell them the result will be there within 1 hour. Yeah, I'll be back, I'll be back, you know, and how many didn't come back for their results, you know? So the first testing session I did, I was in a hospital in Warsaw, and I did 15 people in 1 day, and of those 15, 7 came back positive, RNA positive. What scared me is 4 out of those 7 were negative 6 months before that, when they were treated, when they were tested in jail, RNA negative. Within 3 months of moving to the hospitals, they were sharing injecting equipment and contracted the virus. You know, so there were a couple got tested, didn't come back for the results straight away. And I thought, damn, I don't have the list of medication they take to refer them to the nurse. So it's a lesson learned, you know. So the next testing session, I make sure to ask them all the questions I needed to ask them whilst I have them in front of me. And this is, I think this is primordial to do this kind of work, you know. Whatever you need from service users, get it done while they're in front of you. Well, as we learn the hard way later on. Thank you, Aidan. So this is what I did. I did 22 testing sessions, so just over 6 weeks of work. And so I went across 14 venues across the West Midlands. 7 individuals got referred into OST as a result of me pushing them into it. And this is what I've done. So in 22 testing sessions, managed to get 141 tested. Of those, 71 were antibody positive. Of those, 41 were RNA positives. And I'm glad to say that out of those 41, 30 had started treatment, you know, and obviously we lost 3. 1 died, unfortunately, a week after taking the medication. Nothing to do with medication, by the way. It was a cardiac arrest, I believe. And 2 we lost, you know. So proud, you know, that with this collaborative work enabled us to start 95% of those tested RNA managed to start treatment, you know. So it was wonderful. Thank you, Aidan. We had some hiccups, obviously. One in particular I thought was great, was in, where were we, in Staffordshire somewhere. I was with Sarah, one of the nurses, and we had the meds, you know. We phoned the service user. There were 2 of them living in a shared house, and literally, yeah, we come in. So 10 o'clock, we come in. 11 o'clock, we come in. 12 o'clock, we come in. So like, Sarah, let's go. And we just knocked on their door, and they were like, oh my God, this is so good of you. Can't believe you just done that. You know, wow, that's a service and a half, you know. So it just shows if you got somebody pragmatic with you, it can be easily done, you know. So that was those 2. One was an FA and was scared of losing his meds. The poor guy was in really in a bad state, you know. So heroin and crack, too many benzos and alcohol. The poor guy doesn't know that, yeah, the day of the week, you know. But due to a fantastic and very proactive and caring pharmacist in Coventry, she agreed to issue his meds. You know, I phoned her and I said, listen, this guy comes in and gets his methadone from you. He's worried that he's not going to cope with this medication. He'll forget, you know. And she said, well, I'll tell you what, I'll give it to him. You know, how long's it for? I said, well, it's 12 weeks, you know. And she did, you know, and she needs to be praised, you know, as a result. What a fantastic piece of work that was. Well, the couple, we had one in particular knows answered a phone, you know. She was very wary about a new partner finding out about the diagnostics, you know, and she refused treatment. The drug worker or the clinical nurse specialist based on the drug service agreed to give her the meds at the next prescription review, and she refused, unfortunately. So that was one of the 3 DNA that we lost, you know. What else? Thank you, Aidan. So that was the first lot, 22 testing sessions. Then I had to give the machine back. So I was a bit heartbroken, to be honest with you. I was like, damn. Eventually, within a few months, I got another call to say there'll be another machine available. You know, I thought, okay, this is brilliant, you know. So MSD told me that we'll give you another one for 1 year, okay, 12 months. But we need to warn you that from the moment you take it out, the countdown will start. And I thought, okay. So again, I made use of my existing links and foundations that I built, you know. Sorry, I've just read a comment. That was very funny. So round 2 of the Birmingham and West Midlands Cepheid Test and Treat Roadshow, round 2, started in September 2020. So we're now 7 months in. So I've done 366 tests so far. Out of those, 165 antibody positive. I got 84 RNA positives to date. Also to date, 49, no, sorry, when I send you those slides, Aidan, there's 2 more started treatment. There's 51 started treatment, and I found 46 SVR12, and most of them was for the first batch of Cepheid testing that I did. So I think it's working well. I have now some colleagues that join me. The team has grown in Birmingham, you know. So I've got more colleagues, got more peers, you know, and the stats show. I think they speak for themselves, you know. Thank you, Aidan. I think I'm up now time-wise, so I just wanted to leave with a couple of gratitude shots. So thanks, Aidan. The first one you'll see is the wonderful, oh, here we go. That was the second testing event I did, I think last year. That was in Stoke-on-Trent Hostel. So there you are set up in the room. The middle picture, one of the CNS, one of the best I've had, and she sadly left us to work in a GP surgery. I should have took a picture out. She doesn't deserve to be on there. No, this was the wonderful Clara Jeffrey that used to cover Staffordshire. So Debbie, Moore, Sarah and myself, who were the 3 musketeers for Staffordshire. And I think we did tremendously well, you know, in that part of the world. And the last picture is the equally wonderful Stacey Chambers, the CNS from Coventry, who's threatened to either interview me with a fibroscan or, thanks, Aidan. And I thought I would save the best for last. With a little case study for this guy. We're in Stafford with Sarah, the nurse. A guy walked in, his worker told him to get a test. And his word when he walked in the room is, are you going to effing tell me if I've got Hep C or not? So we looked at him. I said, well, of course, that's what you're here for. He said, no, you don't understand, because this lot, mentioning, well, pointing at the drug worker, telling me I don't have it, but the hospital tells me I have it. So Sarah looked at the hospital notes, found out that, you know, he was diagnosed 4 years before that, genotype 1, I believe, 800,000, viral load. I asked the drug worker to show me the results from the laboratory that they used, and is antibody negative. So therefore, they never reflects, PCR testing. So as far as that concerned, is antibody negative, So, okay, I said, I did a mouth swab on him, and he came back negative. So cephed him, and he's back positive. Very similar viral load, quite high, 900,000 by that time, I suppose, So Sarah and I were a bit baffled by that, Did a bit of research, spoke to a few colleagues afterwards, realized that this poor guy has never seroconverted, So I'm aware there's not many cases of these. I know it's more popular with people that were infected with HIV, but that really gave me a little waking up call, So yeah. 2 weeks later, we were back with his medication. He just opened up the box. He opened up the tub. He went to the drinks machine in the drug service reception area, took a drink. He was so proud to show us that he literally started treatment there and then. That's it from me. Thank you so much. Thank you.
Thanks very much, Philippe. Some fantastic work there. And I think, a bit of an emerging theme from all of our speakers is that the two most important things seem to be persistence and offering free food. So that's good to hear. So we've got time now for just a few minutes for some questions before we move into the breakout groups. So I think one or two were sort of answered during the course of the presentation, but I will kick off with a couple of linked ones for you, Helen. So I think someone wanted to know whether you have a prescriber there as part of the team so that you can test and treat in 90 minutes. And then on a similar question, someone asked, how did the unnamed meds work? Did you take pre-packs of meds dispensed by your pharmacy, or pre-packs of meds dispensed by an external company? Or did you have a pharmacist as part of the outreach team to dispense for the patients you decided to treat?
We've got 4 prescribers. So yeah, every time we went out, there was always a prescriber. So what we did with the pharmacist, we would pre-order medication. So we would say, could we have 6 lots of 12 weeks of Eclusa or Mavorut, either one, because they were the pangenotypics. And they would give us a code. So they would give us a 007, 0010, whatever it was. So, and they would give them and mark them in a book, and that they'd given them to us. And then every time we dispense them, we all have laptops. So every time we dispense them, we would do our prescriptions are done electronically as well. So we electronically would do our prescriptions, and we would write in the comments that this was a 0010 patient 1, 0010, and then we would do a blue tech. So it doesn't happen in other places because we've tried to get people to do it in the rest of our ODN, but it doesn't happen. But our pharmacy were happy for us to do it. But yes, you have to have a prescriber who goes out. Unfortunately, there are 4 of us there were 4 of us, one's left, but 3 of us that are prescribers.
Thanks, Helen. That's great. And I think a slight follow-up question to that was also who completed the blue tech and when?
We did the blue tech when we were on site as well. So again, there was quite a few staff. There was, say if it was me, I'd be the person doing the blue techs and the prescriptions. Then we'd have the Hep C trust who'd be doing the antibody tests. And then we would also have another member of staff who would be doing the Kefir machine type thing. So yeah, but everything was done on site.
Brilliant. Thanks, Helen. Philippe, on a similar note to you in terms of prescribing, someone wanted to know what the process was for the prescriber in your outreach work.
Okay, I mean, literally at the end of the day, I would go home. Well, before I went home, before I pack the machine away, I would use an encrypted USB stick for the result to put from the machine, the computer onto the stick. I would go home, send the result to the CNS via secure email, and also the MDT form with the list of medication that the patient is on, for example, and details. And then they would take them to the next MDT blue tape them and get the meds sorted and delivered. So yeah, time frame, yeah, varies 1 to 2 weeks, 10 days, vast majority.
Brill, thanks, Philippe. Rob, I've got a question for you, which is obviously there's a few ODNs have had vans approved and people are starting to get their vans soon. I just wondered whether you had any sort of general kind of key tips or advice based on your experience having done this for a few years.
I think it's just about that persistence and, you know, just keeping the van well stocked with stuff and making sure you've got all your supplies when you go out each day. Do you know what I mean? I don't think there's been any difficulties with the van itself. You know, it's just a mobile clinic, really. That's, you know, it's like working anywhere. It's just a clinic, and it's just about how you manage the numbers of people in that. Do you know what I mean? Within that small space that can be quite difficult. Yeah. Yeah, I don't think there's any really key learnings from the van, really. You know what I mean? Apart from that, it works really well, and you get really great engagement. You know.
That's great. Thanks, Rob. I'm sure people will want to kind of pick up on that sort of stuff in the breakout groups. So I'll just finish this with a question to you, Louise, which is that obviously outreach has changed a lot during COVID. And I wondered whether there's just sort of changes in the way that people have gone about things that you think are positive and that should be continued even as we hopefully start to emerge from some of the closures.
Yeah, I think typically the outreach worked well doing it in drug services because you could combine it with prescribing clinics, with needle exchange transactions. But I think being able to actually go and visit patients where they're at. I mean, my colleague, we've got a van in Hampshire, and I was just going to reply, one of our biggest considerations at the moment is where we secure park it, because we had it broken into, and because it was specialist glass, it was out of action for 10 weeks. So that would be one of my biggest tips for people. But we were able to go, we took a hepatology nurse and they did about a 100-mile round trip, but there was somebody that they met near their house that we've been trying to engage into Hep C treatment for 10 years. So I think it is about that planning, about looking where the patients are at, and actually speaking to them and building that rapport using find a friend schemes. You know, we've got one guy in our Fairham service that's now on his 3rd course of retreatment, and we've said to him that you just need to tell us who you're sharing with, because we are going to run out of treatment options. So just about encouraging, you know, making sure that you include everybody. You know, Hep C Trust strapline, leave no one behind.
Exactly. Thank you, Louise. And Rob, I think you've answered the question there about just sort of getting the van access. But yeah, I'm sure if people want to sort of pick up any questions for Rob, I'm sure you're happy to be contacted after the session. So thank you again to all of our speakers. Helen, I think you have to pop off. So thank you very much once again for coming along today. Thanks, Helen. Hopefully our other speakers can stick around. So we're going to go into some breakout groups now for further discussion. So each group will have a facilitator. So Philippe's going to lead one and Rob's going to lead one. And then the other two will be led by Carrie Richardson from the Hepatitis C Trust and Tanina Scalacci from the Eastern Region ODN. So you should shortly get something pop up on your screen, which will invite you to join a breakout group. You might even have it now. If you just click join, it'll send you into it. We'll gather back here at about 20 past to hear a quick summary from each of the facilitators. See you soon. Hopefully everyone's back now. So welcome back, everyone. I hope you had some useful discussions in your breakout rooms there. We certainly did in ours. And thanks very much to all of our facilitators for leading things there. So before we close, I'd just like to invite each of the facilitators to give a quick, brief summary of the discussion in their group. Carrie, could I start with you?
Yeah, sure. Thanks, Aidan. So we had a really interesting discussion because we had Jackie kindly went over some of the work he's done with African communities and HIV outreach work. So there was some real kind of themes that came from that. I think specifically within that group, it was about, but it broadens out to other groups too. It's about not not just putting people in one group. So not just saying that's the African community, that's how we deal with these people, this is how we're going to look at our outreach model, but looking for all the intricacies within that as well. And how we consider those. And I suppose that's something that we can look at across the board. We need to be really mindful of not just putting people in little boxes. The other things that came from that, we had a conversation around peers as well, because Roy from the Hep C Trust was in our group, and where he is working, he's trying to engage with the Mauritian community and has a peer. And one of the points that Taku had said is that in some groups, you have to be really mindful of sometimes perhaps having a peer isn't always the best approach, because there's there might be anyway, some resistance around the confidentiality and the stigma within somebody from your own community group being out there and testing. So perhaps there's, you know, it works differently to when we're looking at people who inject drugs in that sense. What else did we talk about? So we also talked about incentives as well, in terms of things that we might have to look at going forward with any outreach that we do. And I think the group kind of highlighted that there is some debate within different regions, different hospitals, etc., around the use of incentives, and is it good, is it bad? But I think in general the group felt that they are a very useful tool, as long as they are used at the right time to engage with that person. So perhaps looking at making sure that incentives are used not necessarily just at the start, because then you might lose somebody. They are used further down the pathway as well. And I guess what the incentives are as well. And I did say somebody in our team recently at the Hep C Trust, they had talked about incentives, where I think it was a conversation because there'd been some resistance around the use of them. And what he described it really well, because he said, you know, actually, this isn't about saying we can't engage with people, but sometimes if you have an awful lot of people around you, it's a catalyst to engagement, because you can just, it speeds everything up when you're working with a lot of people in a big group, and then you're still going to do the same work you would have done anyway. It just makes that hook a little bit easier. And I think that is probably it. I don't think I've missed anything. Yeah, I think it was the main thing was just to make sure that we don't kind of label everybody with the same approach in terms of outreach. Oh, and sorry, I've just remembered one thing. So one of the other key points was Taku was talking about the fact that we shouldn't just look at the groups kind of within our sector as partners. So not to just look at, you know, a drug service, a needle exchange, a pharmacy, also look at things really within the community. So we had a conversation about things like football clubs and barbecues, boxing, things that are a little bit away from what we would normally do, but are actually really properly within kind of the community group of the person, and how we could perhaps look at that going forward as we find that we're treating more and more people. That may be a route to go down.
Thanks, Carrie. That sounds like a really interesting discussion, and thanks, Taku, for coming along and sharing your experience as well. Really appreciate that. Tanina, could I come to you next?
Of course you can. So we spoke a bit about outreach vans and how it was good to get as close as we can to the underserved community members that we're trying to reach. We talked about branding and whether we should have branding on the vans or not, how it could be a good way of raising awareness when you're out and about just driving around, but potentially when the vehicle is parked, we don't want, didn't necessarily know if that was always appropriate. We spoke about social distancing and about disclosure, so just so people are aware to give people a bit of space when testing's happening or when they're in a clinic room. Marigold spoke about her work within HIV and within migrant communities, and about some of that was about raising awareness, and not just about HIV, but also raising awareness with regards to sexual health, how viruses and diseases can be spread, some of the barriers around language barriers. People may live in poverty, so they may not necessarily want to spend money on getting somewhere to get their treatment, and just bringing an overall awareness to lots of different groups. And remain confidential. Some people aren't aware of cultures and how cultures are different in this country to other countries.
That's great. Thank you, Tanina. And again, thank you for coming along as well, Marigold. Great to have your experience as well. Rob, if I could come to you on your group.
Yeah, we were just sort of having a general discussion, you know, about things in general. But I think two of the main things that came out of the group was incentives and how they work and how they can work really well. Do you know what I mean? For instance, like somebody coming to get tested, then maybe offering them other incentives to bring their friends as well. Do you know what I mean? That's worked really well. And we were talking about how data is collected as well and how it's fed into other services, and where there's a lot of data missing, where for me maybe where we're picking up people that are in opiate substitute treatment and not feeding that back to the opiate substitute treatment services, so it gets included in NTDMS and stuff like that, so we don't get a whole picture of what's actually happening with the client. Yeah.
Thanks, Rob. Again, sounds like a useful discussion there. And finally, Philippe.
Thanks, Aidan. Yeah, so what was really interesting in our group is we had some colleagues from Scotland and from Wales. And for any English guy here, we are lucky. We need to count our blessings, because our colleagues in Wales and in Scotland, they're struggling, you know. There's no Wales in van. There's no van in Wales, I should say. And they're getting their first Cepheid machine soon, hopefully, because I know it's been picking to me now over the past few months, you know. So, yeah, they definitely need some more tools to go and take it there, because as Debbie from you know, rightly said, you know, outreach can be life-saving to some people. You know, if he wasn't first going after them, they'd be completely ignored and just left there, you know. Well, not ignored, but, you know, there was somebody, if it's Mike or if I'm mentioned an initiative in London, which I thought was great, you know, when we talk about incentives, yeah, they've done a SIM card initiative where they would buy a SIM card for the service user and they would like enter them into some kind of contract, I believe, if I got that right, you know, and obviously should they sell the SIM card or whatever, then obviously that out of the contract, but it's a good way to keep them engaged, you know, remind them about appointments and stuff like that. So I found this incentive brilliant, you know. I must say, I don't want to sound, you know, I've never used a single incentive in my life to ask somebody to be tested. However, I'm fully aware how brilliant they can be when you don't want to lose them. You know, when you get somebody, you know, you're cirrhotic. I'm sorry about this. It could be some background noises. Some idiot is blowing some leaves with a petrol thing, which is beyond me. Sorry about this, guys. Yes, also what Debbie said is so right. We need to keep going to them and to persevere. You know, we really need to persevere. Going back to my incentives quickly, we know cirrhotics need to be seen twice a year for ultrasounds. You know, so it'd be great to use incentive for those. You know, to keep an eye on them, because the consultants need to see them, and especially as we know, the genotype 3s. You know, we know that the ones that are likely to develop cancer. So, and I can tell you, there's 2 guys every week I'm trying to get to the hospital, and it's not happening. I've got them in me. I'm in the hospital with them. The car is parked outside. It's just not happening. No, Philippe, I need to go and speak to the prescriber. I need to go and see the nurse for my leg. You know, not happening. They're not going to the hospital for ultrasounds, you know. So if they're going to be twice a year, we'll have to be clever about that. That's it. That's it. Thank you.
Thank you, Philippe. Perfect timing, because we're just hitting past. So I'll draw things to a close now. As I mentioned earlier, we will be adding the recording to the website and the HCV Action YouTube channel in case you want to return to anything or send it on to colleagues. And we'll also produce a summary report which will circulate. We will also be sending around a survey via Eventbrite shortly. So it'd be much appreciated if you could fill that out just to help us with kind of planning future webinars. Yeah, finally, just to close, thank you very much once again to all of our speakers and the breakout group facilitators, and also just to everyone for coming along today and sharing your experiences. And we'll see you soon. Thanks.